All right. Good evening, everybody. Thank you for joining us today. To those of you in person and joining us on Zoom, welcome. Good evening. Thank you for being here. I'm Laura Bacher. I'm the Dean for Educational Affairs here at the School of Medicine. I'm also a professor of OBGYN at Tufts Medical Center. So this is a topic near and dear to my heart, and I'm glad that you're all joining us today. I want to welcome you to tonight's Tisch College Solomont Speaker Series event. This is called The Aftermath of Dobbs, Abortion in America, which is jointly hosted by Tufts School of Medicine as well as Tisch College. Before we get started, I wanted to thank today's co-sponsors, the Public Health and Professional Degree Program here at Tufts, the Center for Black Maternal Health and Reproductive Justice, the Tufts Democrats, the Political Science Department, and Tufts NARAL chapter. Your collaboration, along with the support and leadership of Susan and Alaman Solomont, make timely conversations like this one possible. There are many folks involved in tonight's planning of tonight's event, but I would especially like to thank Deans Aviva Must, as well as Dean Amy Kulik, also Jennifer Greer-Morrissey, who is our Tisch CSL leader, for their invaluable partnership making this event happen. The Tisch College Solomont Speaker Series is now in its 8th year of bringing leaders and change makers to our campus from all walks of life to inform, inspire, and challenge our students and the Tufts community. Tonight's conversation will focus on the United States Supreme Court decision in Dobbs versus Jackson Women's Health in June, which overturned the constitutional right to abortion in the United States. Excuse me. Should not have used double-sided paper. Just sticking together, maybe in the fog. No matter what your personal beliefs or perspectives, this conversation is going to be a difficult and challenging one to have, but also an important one to have. This has been a pivotal turning point for the future of healthcare in America. This program tonight will aim to help us make sense of this decision from different perspectives, process its effects together as a community, and ask questions about what Dobbs means for patients, providers, the future of healthcare policy, and the future of our rights. We are fortunate to be joined this evening by a panel of highly regarded professors, medical and legal professionals, and advocates, many of whom I call colleagues. In addition to introducing them to you now, I'm excited to be in this conversation with them also as the moderator for tonight's discussion. So first, on the left, Dr. Danielle Roncari. Dr. Roncari is an associate professor of obstetrics and gynecology at Tufts Medical Center. She serves as the director of family planning and the director of the Ryan Residency Training Program. Dr. Roncari completed her residency training in obstetrics and gynecology here at Tufts Medical Center, and she went on to complete her fellowship in family planning at Boston University, where she also received a master's degree in public health. Among her clinical expertise is second trimester abortions, complex first trimester abortion, and complex contraception provision for medically complex patients. Thank you, Dr. Roncari, for joining us. Dr. Nina Ashford is an assistant professor at the Department of Public Health and Community Medicine at the School of Medicine. She also serves as the policy lead for the Tufts Center for Black Maternal Health and Reproductive Justice. She is a former federal government director committed to health equity through innovative person-centered policy, public health programming, and evaluation. With over 15 years of experience working across multiple sectors, including government, academia, and research, Dr. Ashford holds a doctorate and master's degree in public health from the Milken Institute of Public Health at George Washington University, a BS from the University of Wisconsin-Parkside, and a certificate in business administration from Georgetown University. Thank you, Dr. Ashford. And then in the middle, we have Amanda Hamesworth. Amanda is the Assistant Attorney General and Managing Attorney of the Civil Rights Division of the Massachusetts Attorney General's Office. She is responsible for enforcing and safeguarding constitutional and statutory civil rights on behalf of Massachusetts residents and visitors. Among other areas, Amanda is responsible for managing the division's work on reproductive rights, police accountability, and algorithmic discrimination matters. Prior to joining the Attorney General's office, Amanda was a senior litigation associate at Foley Hoag, hope I'm pronouncing that right, Hoag, where her practice was focused on white-collar crime and government investigations. A Brown University alumnus, Amanda earned her JD at Northeastern University School of Law. Thank you all so much for joining us tonight and for sharing your perspectives and expertise with our community to help us better understand the Dobbs decision and the impact on abortion in America. And again, thank you to you all for joining us both in person and on Zoom in tonight's discussion. Please join me in a brief welcome to our panelists. I'm not going to stand the whole time. I'm going to ask the first question to our entire panel. So feel free to answer if you feel like this is appealing to you. I will also direct some questions to individuals as we proceed. So for this first question, I think a lot of people were shocked with the Dobbs decision, while others had long anticipated it and maybe welcomed it. Can you talk a bit about your reactions to the decision when it was announced and where you're at now that several months have passed for you to process this decision?
I had a unique position when Dobbs was announced. So, of course, I was one of those people that saw it coming. And, let's be honest, abortion has not been accessible for many, many, many Americans for decades, really. So, this was just kind of the court decision. But before that, it really wasn't accessible. And I was actually taking care of a patient. Teaching, like I often do, teaching a trainee on how to provide abortion. And I got an alert on my watch and I just happened to look down. I was not the one performing, I was observing. So I happened to look down and saw the news flash and was incredibly sad. I think at that moment, I think there was a lot of anger from a lot of people around the country at that time, but I was just incredibly, incredibly sad. Looked at that patient, just, she obviously had no idea what was going on. And got back out of the room to my colleagues and we just all sort of gave each other a big hug and started to cry. So I think now I'm still incredibly sad thinking about, the patients I take care of, the patients that won't be able to access care. But it's been replaced a little bit with anger. So.
All right. Hey, can you hear me? All right. I share the same feelings. When the draft decision was leaked, I was like, well, maybe this is part of the strategy because when the final ruling comes out, it's not going to really be that bad. It won't be that restrictive. And then, that didn't actually come to be. And I remember having this feeling of disbelief, like we knew that it was coming, but we didn't really know what it was going to look like. And then this moment where, where I was listening, they were like, and here's the decision on Dobbs. And then I heard the decision on the gun stuff. And I was like, dang, guns have more rights than I do in this country. And I have many emotions and feelings about that, being both a woman and being both an African-American woman. And so I think as the time has gone on, it's, still sadness, but it is getting more and more consumed by what I would call a simmering rage to how, what do we do now? Let's mobilize, let's act, let's fix this, let's figure out what we need to do state by state, since we no longer have this federal protection, but that's where I'm at.
Slide that back.
Does that work?
Yeah.
Yeah. Okay. Yeah. I think same feelings for me. In the AG's office, we began preparing for Dobbs in the fall of last year when we saw how the court was responding to SB 8, which was the patently unconstitutional abortion ban enacted in Texas. So, we knew based on the way that the court was responding to it that we were in for a hostile ruling in Dobbs. The question was just, for us, whether they were going to reverse Roe completely or whether they were going to take a more incremental approach. And then, of course, with the leaked draft opinion, we saw exactly how far the court was poised to go. And so when the decision actually came out, there was no surprise. It just, as others have said, it was just sadness and concern, for people who were about to lose healthcare, in some cases immediately. And so, for us, we had started working in the fall on preparing. And we just increased our efforts. And I'm going to be talking a lot about, I guess, the work that we've done throughout the panel. But, some of that has involved legislative work in Massachusetts. Some of that has involved intensive work around data privacy and digital misinformation. And we've done a lot of work with our counterparts in other state attorneys general offices and with the Biden-Harris administration as well. So I do a lot of work on reproductive rights these days, and we'll continue to do so. We are committed as an office to, fighting back as hard as we can and using every tool in our toolkit to try to expand access and protect our providers.
And at the conclusion, we'll come back to some of these themes about what we can do, turning that anger into action. So that we'll return to that theme. In the meantime, we are here at the School of Medicine. This is an educational forum. And certainly this decision will have an impact on both undergraduate and graduate medical education. So meaning medical students and residents that are in training. And I'm hoping you can share some of what you anticipate might happen as far as the impact on education, both at the undergraduate and graduate level. And this could be for anyone.
I can answer that since I do a lot of training. I think in Massachusetts, obviously our residents are going to still have, in the graduate medical education, are going to still have experiences in education. In the undergraduate, they can also seek out opportunities to access, education about reproductive health care. But, we're also limited in how much we can do. And so we are seeing a lot of requests from patients or from schools and students from around the country that want to get this experience as well, because it's such an integral part of women's healthcare, reproductive healthcare. And the opportunities just aren't there around most of the country. And there's, it's not just as easy as sending a student or a resident up to Boston to get exposure, because A, we have a responsibility to our students here, and B, there's all sorts of laws around, can the student from a state where, abortion is banned even come up and have an experience in another state? So logistically, it's really quite challenging. I think there's been a smattering of students that have been able to move across the country. But it's just, certainly we can't fill all of the needs for education. And I will say, as an OBGYN, that abortion training has been integrated into the curriculum and sort of a required part of training when you leave residency. And so the people that sort of govern OBGYN residencies are trying to figure out what that means in this new world. How do you mandate something where it's incredibly difficult for your learners to get access?
On a related note, are you aware of any efforts that medical schools or training programs are doing to ensure that their own trainees, if they're in a restrictive state, might have access to care, or any kind of adaptations from that regard?
In terms of care, I haven't heard anything in terms of care. A bunch of schools have reached out, but again, it's been a little difficult for learning opportunities. But you probably know better.
I think a lot of, and it's a collaboration with what's going on with the legal aspect of it. But my understanding is that there is work being done with the Ryan program, as well as through the AAMC and through some of the OBGYN professional societies to try to create a network, both of care and for clinical experiences, but lots of hurdles to get through before that could be implemented. So. All right, actually, and this question, Danielle is or Dr. Makari, is directed for you. As far as residency training in different states, are there any collaborations that you know of for fellowships? Fellowships do exist in states that are now restrictive states. What happens to those fellows that are in training?
Yeah, so the Society of Family Planning kind of joint hosts a fellowship in complex family planning, and an integral part of that is getting really a lot of experience in abortion care. And there are states, for instance, there's a program in Georgia, a very well-established program, and they've made some relationships with some surrounding states to be able to get their fellows care. And other programs have just decided not to take fellows because they won't be able to get the experiences that they need. And
Nina, I'm going to ask this next question of you. You're the policy lead for the Tufts Center for Black Maternal Health and Reproductive Justice here at Tufts School of Medicine. Can you share what some of your goals are as an organization, and how you anticipate the Dobbs decision may affect those goals and the center's work?
Yeah, thank you for that question. So the Center for Black Maternal Health and Reproductive Justice is relatively new. Both may have seen the press release, but we were launched in April of 2022. It was the vision of our director and founder, Dr. Amuta Onakaga, and an extension of the Mother Lab, which is now one of the 6 units within the center. And the center really works and is driven to try and address and I would say obliterate the disparities that are happening in terms of Black maternal mortality and severe maternal morbidity, which we know disproportionately affects Black and Brown women. I'm honored to be part of the center as the maternal and child health policy lead, and we really see the goal of this center to be the go-to, right? We want to create evidence. We want to, through policy analysis, we want to be part of the legislative process. We want to be the center that policymakers and legislators, both in the Boston area, the state of Massachusetts, and even federally, come to and say, hey, we are working on this bill. We're working on this proposal. Do you have data? What is the impact on, Black maternal health outcomes? And so that we can be seen as a critical stakeholder as policies are made, as legislation is passed, to try and close the gap and address the systemic racism that we know is really the underlying cause of a lot of the mortality outcomes, maternal mortality outcomes that we currently see. I think the Dobbs decision just made the impetus and the need for the center that much greater, right? We know that this decision is going to disproportionately impact Black and Brown birthing people, right? When you look at the states that either had immediate bans once the SCOTUS decision was passed, or are, abortion hostile and actively working to restrict abortion access, those are predominantly located in the South and in the Midwest, which is where the majority of Black and Brown birthing women live, right? So when we look at every woman and birthing person is going to be impacted by Dobbs, right? But when you layer that on top of the maternal mortality crisis we have in this country, it is going to hit Black and Brown birthing women particularly hard. And we are going to have to work very hard to make sure that we have the data to monitor the impacts of that, right? To assess what's actually happening, but try and figure out how do we address some of those underlying root causes of the disparities, of the systemic racism, of the implicit bias and the care that these women and birthing people are receiving, in the event that, they don't live in a state where access to abortion is a constitutional right. So I think the imperative for the center is more important than ever. I'm channeling Dr. Ao and saying, if you are interested in supporting our work, we can always use funding. If you want to help and volunteer time, that is also welcome as well. Please, don't hesitate to reach out. So.
Great. Thank you so much. And Amanda, this question is now for you. Okay. The Massachusetts Attorney General's office has actively been fighting to protect reproductive rights as well as gender affirming care for years. And you've been a huge part of that effort. I'm wondering if you can share with us what some of the barriers patients are now facing in the wake of the Dobbs decision as far as accessing abortion care, and what states that are more progressive and supportive of abortion rights are doing to help support that care elsewhere.
Okay, it's a big question. So I'll start with barriers, and then I'll talk about what states can do. So as Dr. Roncari said, abortion access has always been highly restricted, and there have been numerous barriers for people to access abortion care. Medication abortion is highly regulated, and as a result of the steady erosion of abortion access in different parts of the country, it was already very difficult for people to access care in large portions of the country. What Dobbs did is pave the way for state bans, which just places abortion out of reach for, a huge segment of the country. So, that leaves patients in those states with really 3 options. One is to try to travel, but travel is costly. It can be practically difficult. It can be unsafe for people who are in domestic violence situations. It can be practically impossible for people who have, job or childcare responsibilities or live in rural communities. So that's not a good option. Option 2 is to try to access abortion pills through an online pharmacy, and take them without medical supervision. Medication abortion is very safe and widely used, but I think research would show most patients would prefer to manage their abortion with medical supervision. And there are barriers to accessing abortion pills online. Putting aside the bans for 1 second, most abortion pills that are coming into the US through the mail are coming in through foreign countries, and that takes a long time. So it's difficult, and it's not a great option. And the third is to just forego an abortion, which is also not an option for most people. So the barriers are huge right now for a large segment of the population, and for many, it just puts it too far out of reach. As far as, I guess one other thing I'll say is I know that the Society for Family Planning is putting out data, I think later this month, so it would be later this week, that shows that in July, in the month after Dobbs, there were 7,000 fewer abortions in the country. The surge, the patients who are traveling to states like Illinois and Michigan and a handful of others, not the Northeast generally. But that if that 7,000 number holds, and I think we have every reason to think that there will be further restrictions. So if anything, I would think it would go up. We're in for a significant reduction in abortion care across the country in the year after Dobbs. So, those are the barriers. That's what it looks like right now. As far as what states can do and what we have done here in Massachusetts, I think there's really 3 big buckets of work. One is what we have done, which was to try, we immediately did a lot of outreach with our provider community in Massachusetts and with experts to figure out what we needed to do to make sure that our providers felt safe and secure, continuing to provide care not only to people who live here, but to people who travel here for care, and also what else we needed to do from a policy perspective to try to expand access and reduce barriers here in Massachusetts. The result of that was a bill that we drafted along with our partners at Reproductive Equity Now, GLAAD, and the ACLU of Massachusetts that puts in place protections for abortion providers and also providers of gender affirming care, because we're seeing very similar criminal bans targeting that care as well. Trying to sort of, remove our state institutions, our legal and medical apparatus from facilitating out-of-state consequences for those providers. And I'll say more about that in a second. And secondly, the bill also had a number of provisions that expanded access in Massachusetts, particularly around medication abortion. So that law was signed by the governor in July and is now in effect. So it's called the SHIELD law. I think some of you might, see that in the press. And what it does again is it says that if you are a provider, an abortion provider, or a provider of gender affirming care, you're in Massachusetts, and you provide care that is compliant with Massachusetts law, then you could avail yourself of the suite of protections, regardless of the patient's location at the time the care was provided, which for those who are familiar with telehealth, that kind of flips the telehealth rules on its head. But we think it's really critically important for providers to continue to feel safe and secure. So, for example, if you are licensed here in Massachusetts and you send abortion pills or treat or have a follow-up appointment with a patient in Texas, Texas may pull your license, but your Massachusetts license isn't going to be impacted by anything that Texas does. Same for extradition. If you're charged in Texas, we can't stop Texas from criminally charging in state courts, but we can say that our governor is not going to be involved in extraditing a provider or facilitating those consequences in Texas. Same for medical malpractice, professional liability insurance. Your premiums can't be impacted under Massachusetts law if you have been charged or are the subject of a civil judgment in another state. So there's a whole bunch of, weedy provisions that are designed really to try to help make our provider community feel safe and secure, and that our institutions, our courts, our law enforcement agencies are not going to participate in helping bring about or facilitate consequences in other states. So a bunch of other states are looking at doing this. A couple of states have done it. The laws don't look the same. But there are versions of this in New Jersey, in Delaware, in Connecticut, in New York, and there are pending bills in California and some other places as well. So I think that that sort of shield law concept is gaining some traction, and that's like definitely one thing states can do. Another is using our existing tools in our toolkit, our civil rights laws, our consumer protection laws, to try to ensure that people's data, for example, people's information that they have out in the public domain is being used in a way that's compliant with our state law. So looking at data brokers, for example, how are they collecting information? Where is it going? Do they have the right safeguards in place? And that's not a new thing. We've been doing that for a long time. We had a settlement in 2017, so well before Dobbs, where we had an advertiser in Massachusetts who was geofencing around abortion clinics. So if you walked into this fence, basically this virtual fence, this geographic proximity around the clinic, you would have crisis pregnancy center ads pushed to your phone. So we address that. They're prohibited from doing that in Massachusetts, and there's a settlement agreement in place. But we're, that's an example of the type of work that we can do in Massachusetts around data privacy, digital misinformation. And then the third is really supporting litigation and policy proposals in other states and at the federal level, so we can file briefs or we can write letters, and we often do this in conjunction with our counterparts in other access-oriented states to really kind of lend some force to either what's happening in litigations brought by nonprofit groups and others, or the federal government, and also supporting federal policies that are intended to expand access. So that's a long answer. Those are three examples of the types of work that states can do. There are many other examples, but those are kind of the core things that I think we're all thinking about right now.
It's really, really fascinating. It sounds like a very multi-pronged approach. And thank you for all of that hard work to protect our providers. So Danielle, as a provider, what changes are you seeing in the patients that you're taking care of since the Dobbs decision? And in your expertise, in your opinion, what directions and long-term impacts might patients face in light of the Dobbs decision?
Yeah, I mean, we are seeing an increasing number of patients coming from out of state, something that we haven't seen before. And, most of those patients, not in droves, I think like some other states like Illinois, but certainly people are getting here. It's most often patients that have some sort of connection to Boston. It seems like everybody has a connection here. So, my sister's in school, or I used to live here, or I went to school here, or something like that. So we are seeing a handful of those patients. And it's, I would say as a provider, it's really challenging. I tell my staff all the time, like we want everybody to get the best possible care and no complications and everything to go super smoothly. But it's like for somebody that's then traveling back home, we want it to be perfect. And like, that's just not medicine, right? Medicine's just not always perfect. And all the same complications, abortion's incredibly safe, but all the same complications that can happen if you live in Massachusetts can also happen if you also then have to go home to Texas. So it's been very challenging trying to figure out how to kind of best take care of somebody and then what to do when that patient then goes home and what sort of avenues do they have once they get home in case they do need something beyond the care that they had here. So that's, I think really been a big challenge. And I think it's really hard, particularly for younger staff people and younger providers to really kind of understand you can't like always make it perfect. So what was the second part of the question, Laura?
What long-term complications might patients face if they are unable to access abortion?
So there was a study done a while ago pre-Dobbs on it was called the Turnaway study. You probably all saw it in the papers. It was originally really a study looking for people that were turned away for an abortion because they were too far along for the abortion. But now in this sort of, post-Roe Dobbs era, it sort of has it's become even more important because we know that what does happen to patients turned away is that, they don't seek as high education. They don't have the same opportunities. They have, worse health outcomes for themselves and for their families. So, we do know. And I think the other important part is, this can potentially have broader implications on the healthcare system in general. We're already seeing higher numbers of applicants to residency programs in the Northeast and people not wanting to take jobs and leaving jobs in centers where they can't provide full spectrum care to their patients. And I think when we talk about disparities in worsening health outcomes, not having a really highly skilled, trained workforce potentially could have a lot of long-term outcomes, particularly in rural areas where it's already difficult sometimes to recruit. This just adds like another layer of difficulty to that.
I'm going to turn our next question to you. In a recent documentary that I think a lot of our students have watched, Aftershock, this is a tragic story about 2 fatalities among young Black women. Dr. Neil Shah stated that he believes that, this is his quote, "the well-being of mothers is the bellwether for the well-being of society in general. And that's why every injustice in our society shows up in maternal health and maternal health outcomes." I'm hoping to get your thoughts on that statement, and also whether you think these topics are a spectrum of reproductive rights, and that whether we need a separate conversation with different outcomes.
Great. Thank you. So first, just a plug, if you've not seen Aftershock, go stream it on Hulu, get your Hulu login or your friends or yours, and go watch it. It's very good. And I particularly appreciate that they tell the story through the eyes of the Black fathers and partners who lost their loved ones. So I think when we think about abortion access, maternity care, and overall healthcare access, they are integrally connected, right? And the fact, just to Dr. Shah's statement that maternal health disparities and maternal health outcomes are a bellwether for the rest of society is absolutely true. I think you can look at any of the disparities that happen across the pregnancy period, whether it is the maternal mortalities that we're seeing. We know that Black women are 2.5 to 4 times more likely to die during childbirth, whether it is the increased disproportionate prevalence of chronic conditions that Black women enter pregnancy with, which further exacerbate some of the severe maternal morbidity, and these negative outcomes increases risks for things like preeclampsia and gestational diabetes, which leads to these issues that we see kind of driving some of these maternal deaths, whether it is early access into prenatal care, right? We think about healthcare access. We think about the fact that Medicaid pays for 40% of all births, right? And the reason that woman is probably eligible for Medicaid, particularly in states that also have very restrictive abortion access laws and have likely not expanded Medicaid, is because she is pregnant, right? So she's probably gone a long period of time without preventive care, without wellness checks, with all of those things that would give her an opportunity and access to be as healthy as possible then in that pregnancy, right? And also access to contraceptives to be able to possibly take control of her family planning to begin with. When we look at the postpartum period, right, CDC just released that analysis a month or so ago. 83% of all maternal deaths between 2017 and 2019 were preventable. It's unacceptable. I have a 1-year-old. He just turned 1 a couple of months ago. Some of my students in the audience know this. Like, I can't imagine the hole we are leaving in families and communities and children, right? These women did not have, these were preventable causes of death, right? They did not have to die. And the fact that 50% of these deaths happened 7 days to a year after the postpartum period, right? So they're not even happening during the birthing experience. And I don't want to, Dr. Macari can speak more to that as well be in the room, but they don't have the systems of care to support them. We've seen a number of states actually take action on the Biden-Harris administration's efforts to expand postpartum coverage a year. Most states cut off Medicaid coverage at 6 weeks. For anyone that's had a child knows that you are nowhere near healed physically, mentally, emotionally, spiritually. 6 weeks, I would say maybe give us 2 years. It's a lot, right? But now we're seeing a number of states actually take advantage of this, right? And expand their postpartum coverage. So we're hoping that we're going to see some of that help as well. If we think about perinatal mood and anxiety disorders, we know that Black women are twice as likely to be diagnosed with postpartum depression or anxiety, but only half as likely to actually get treatment, reflective of the general healthcare mental health crisis and the lack of behavioral health providers we have in this country, right? You look at the fact we don't have paid maternity care. Poverty is a social determinant of health. So many women that may now be forced into birth may not have the luxury of a job that offers them maternity leave. And the data has shown that having that protected time for mom to heal and to bond with baby is critical for setting a successful foundation for families into the future, right? So maternal health outcomes and abortion access are a microcosm of the disparities we see in this country, which is driven by the systemic racism, which is very much ingrained to every single system that we have, right? They are inextricably linked and inextricably connected. And I think, one of the things that frustrates me of many things about Dobbs is that not only are we forcing women into birth, we are forcing women into birth in a country that still has not decided and determined that access to healthcare is a human right. We have no compulsory, we have no compulsory form of health insurance in this country, right? So we're forcing women to birth. We are not giving them the systems, the tools, the healthcare access to make sure that they're healthy, that they are not going to put themselves into poverty, which will, have negative repercussions on their families for time to come. It is absolutely a spectrum. The maternal healthcare disparities are a microcosm of what is happening broadly in this country and access to healthcare in this country. So I would 100% agree with Dr. Shaw. Go see Aftershock. It's really good.
Perfect. And I think 2 years sounds like a very reasonable time for the postpartum recovery.
Yeah.
So I'm going to open up a few more questions to the general audience and then to everybody here too. But after the Dobbs decision, I'm wondering what your thoughts are about implications for other rights that Americans may have and take for granted. For instance, larger issues around marriage equality and gender affirming care, but really other issues including health care privacy and access to contraception.
I can talk about it from a legal perspective. So we have we have in this country under our Constitution what we think of as unenumerated rights. They all sort of sound in this concept of liberty. That's the right to marriage. That's the right to contraception. That's the right to sexual intimacy. These are things that are not enumerated in the Constitution. That doesn't say marriage in the Constitution, but they have been recognized over time in a series of cases that locate these rights in the protections around liberty, right? So it started with a recognition of the right to interracial marriage and a recognition of the right to contraception for married couples. And then it expanded to access to contraception for unmarried couples. Then we have Roe, which recognizes the right to abortion. Then we have sexual intimacy among consenting same-sex partners. Then we have gay marriage. They are all part of the same thread. And so what the Supreme Court said in Dobbs, it really said two things when thinking about the future of those rights that I think is relevant. One is that only those protections that are deeply rooted in our nation's history and tradition are protected under the Constitution, that Liberty Clause, right? So everything I just said cannot trace its roots to the colonial period. Contraception, it just can't. So that's one area of concern. The other area of concern is the Supreme Court disregarded the analysis that it undertakes when it's going to overrule a longstanding precedent like Roe. Nothing changed. There was no factual change. There was no legal change. The only thing that changed was the composition of the court. And so when we think about the future of those rights and we think about the fact that they're all part of the same thread, with Roe being right smack dab in the middle, and frankly, the only one of the bunch that could possibly trace its roots to the colonial period, We are in, it is concerning. So I don't see a way in which if a ban on gay marriage, for example, went up to the Supreme Court, it would be very hard for them to address that question in light of how they ruled on Dobbs, announcing this deeply rooted standard. So it's concerning. The court did say, the majority said that, we're not going to touch these rights. We're just talking about abortion because the involvement of fetuses makes this all different. They don't really explain legally why, but that's what they said. And I think, the only thing in all of this that gives me some, hope is too strong of a word, but is that sounds to me like abortion exceptionalism, and the law and the courts have historically treated abortion a little bit differently, not because of any doctrinal or constitutional principle, but just because they view abortion differently. So, as a practical matter, in order for the court to act on any of those rights, the state needs to ban something, and then it needs to work its way up. I personally feel like LGBTQ issues are the most vulnerable of that cluster of rights, are the most recent, and they are targeted, along with abortion by many of these legislatures. So I don't know what the future holds for it. It's hard to predict, but from a legal perspective, that's sort of how I think of it. You can't just excise Roe from the middle of a long line of cases without there being implications or potential implications for other rights.
Were you going to add something, Dr. McCarty? Oh, okay. Very last question. I promised I would end up on a note of empowerment, hopefully. So, we're going to be my last question, and then we'll open it up to everybody. I think a lot of people do want to, want to do something impactful, feel hopeless, and want to be able to do something to affect change. So apart from voting or donating, which are important, what recommendations do you have for people who want to do more?
This seems very simple, but I do think where we are now, we need to leverage some of the strengths and great lessons learned from kind of ground level community-based organizing and engagement. And I think one of the most powerful things that we can do is telling our stories, right? To the extent that folks feel comfortable, obviously, sharing their stories, right? I had 3 pregnancy losses, very much wanted pregnancies, right? That I was able to successfully, manage through abortion access. And I remember having to go pick up my prescription from methotrexate because it's a complicated story. And my OB said, we are going to fill this in the hospital because people have trouble when they fill it at their pharmacies. And CVS likes to give them problems because they know that these pills, the misoprostol and the methotrexate, are used for abortions. And so in the middle of these already very traumatic experiences, right now I'm having to navigate the politics. And this was in 2018 to 2019. So this wasn't even in a Dobbs world, right? And so in a very horrible, a very traumatic experience, like having to go through and then deal with the politics of something that it is my healthcare, right? It is healthcare to make sure that my ectopic pregnancy doesn't kill me and that my 2 miscarriages are successfully cleared from my body, right? And so I think changing the narrative, sharing our stories about what abortion is, what abortion isn't, how it has real implications on people's lives, how it is healthcare, right? It is a conversation, it is a procedure like between me and my provider, no different than a mammogram or a colonoscopy or anything else. But I think that is one of the most powerful things that we can do in addition to voting and donating. If you can't donate or vote, donate your time or donate money to help with some of the networks that are trying to put together access for individuals in states that have restricted access, I would say share our stories.
I would also add that I think probably a lot of you are in the medical field or about to enter the medical field. But, I think the power of your voices sort of as clinician advocates, it does matter. If you ever go to a hearing, I think a lot of times lawmakers really don't understand the medicine behind what we're trying to do. So it's really important to educate yourself and educate others, including those in, positions of power that create laws around why this is important. And if you're not somebody that's like ready to go up there and fight at the State House, I think it's really important, even in your patient's room, when they're telling you their story, that you're able to help them access the care that they need to reduce stigma as much as possible and really to listen to their stories.